Hi, my name is Javed Syed. Here I'm presenting a case of a diabetic tractional retinal detachment that I repaired via pars plana vitrectomy. Like a lot of diabetic patients, this patient had episodic follow-up. Here he presented 6 months before the surgery, at which time we had decided to go to surgery for this ERM, and there was a few tags of traction, but this was going to be a relatively straightforward surgery. Unfortunately, he canceled his surgery and then came back to me about 6 months later, at which time his PDR had progressed quite a bit. Here we can see a significant tractional retinal detachment over the fovea, and there was wolf jaw traction that had progressed over the arcades. So here we're getting inside of the eye with our 25 gauge pars plana vitrectomy. We see that wolf jaw traction. First thing we're doing is trying to relieve all the anterior posterior traction with the core vitrectomy, and then we will go around the periphery and try to amputate any peripheral vitreous attachments to those plaques. So here you can see us doing a shave vitrectomy over the peripheral retina, really trying to relieve any of the traction on these vitreous plaques peripherally that we are able to. And we're just going around. Here up top, as I'm shaving, I see a little bit of an area where there's a small tear there from a tractional plaque. So there's actually a little RRD component up top. We'll address that later. We're going to the back of the eye here in the macula, and we're trying to trying to segment these tracks. So using my cutter, getting underneath some of those tracks when there's space, and then I'm just kind of trimming things up a little bit. I don't like to get too aggressive here. We just want to segment what we can get to easily, and then we can leave a lot of these plaques. We'll trim what we can, but sometimes in these cases less is more. So we can see there's traction connecting the two sides of the macula. Again, we're releasing that here with the cutter. A broad plaque nasally. These nasal plaques, don't interfere with the macula too much, but it's still nice to segment them if possible. We see there's some peripheral vitreous attached here, and then I'm just eating it and releasing that peripheral traction, going back to the nasal retina here and trying to see if we can get a nice segment. So we're going slowly underneath here, and we want to be a little careful because we don't want to ding the retina or cause a break while we're doing this. So just trying to find space here and gently getting my beveled cutter underneath and then cutting here slowly. Same thing here, we're not trying to get too aggressive, just taking what will come. And we're going to create a little segment even in this track. And we can see there's a little bit of tractional break over there too. We'll address that by placing some laser around it at the end. We'll kind of show you that as we go through it. So trying to get a little segment here though, just to kind of protect this break after we laser it. So that looks good there. We've segmented. Going back along the inferior arcade here, trying to get a segment on this area of traction. And again, these are tight spaces, so we have to be careful. We don't want to get too aggressive and cause an iatrogenic break. Here I'm going high mag. I'm using a flat lens and forceps. And in these cases, I kind of take the easiest things that I can and then go back for plaques that are harder. So I'm going to create a little space here. I'm grabbing, I'm seeing if there's space underneath, and I'm just gently pulling, and we're getting a little release there. We're not going to be able to take the whole plaque off. That'll cause a break, so we're just getting some space. And then we're taking our 25 gauge beveled cutter, and we are slowly going there and releasing. And you can just see how that release kind of frees up the retina. Going back to the optic nerve, the hyaloid's still down there with some regressed NVD. We can use our forceps here. It's really taut. We use our forceps, gently release it. That'll create some space if we want to segment the nasal area later. But right now I'm using my high-powered lens and my forceps to peel the retina where that severe ERM was. So we got a nice area where we can get a little grab here. And it's interesting in these sort of ERMs, they are attached to the tags of traction on both arcades. So you can't really just pull it across. You have to pull, and then we kind of see where it's attaching to. And I'll take my cutter in and try to release some of this so that I don't cause a break as I'm peeling. So we're going to peel a little more. And same thing. And I just actually went back and forth a few times with my cutter here. I'm not going to show all of it, but we slowly went back and forth, trimmed what we could, then took the ERM off. We kept on progressing like that until the ERM came off. And I kind of skipped over some of this. The ERM came off, and then I wanted to take off the ILM as well just to prevent reproliferation. So I stained with ICG green. And kind of hard to see here, but I'm just peeling off ILM in a pinch and peel technique. That helps to prevent the ERM from coming back, particularly in these diabetic cases, and in some cases can even prevent or help reduce diabetic macular edema. Getting the last bit of ILM here, and we're being very careful in the papillomacular bundle. We don't want to cause any injury. Going back to wide field here, we've kind of done most of the main work. We're going to get just one or two more little areas of segmentation. Again, just taking the free traction that we can, and we'll address this nasal area. I don't want to get too aggressive here. This nasal plaque is not doing much to the macula, and once we place PRP in, it'll really shouldn't progress too much more over time. A lot of these patients, even after they're fully healed, I will supplement them with anti-VEGF, every 10-12 weeks, really to slow down any further proliferation, at least for the next year or so. I think that really helps them heal, helps prevent rebleed, and helps to control their diabetes while the laser's taking effect. So here we go. We see a little bit of bleeding at the optic nerve and at some of those NVE tags. We went ahead and raised our pressure to control. I placed laser all the way around the eye, and now we are under air. So I've sealed off that area that had the tear up top with laser. And in that little nasal area where I saw that tractional break, that's also been sealed off with laser. If there were no breaks that I had visualized, I would probably just leave this patient under fluid or leave them under air. Because there was one or two little breaks, just out of an abundance of caution, I went ahead and put this patient under SF6. So here we're just going back to the optic nerve, getting a little bit of residual fluid. The air-gas exchange was done externally. I don't show it, but it was very straightforward. And this patient did quite well once the gas resolved. He had a big improvement in his vision. Again, this is Javed Syed. Thanks so much for watching.